Good evening, everybody. Following Dasara celebrations, we are here in continuation of our CCI webinar. Today's topic would be on evolution of antihistamines and their combination. For this, we have two speakers exclusively who's going to talk on evolution of antihistamines and their combination, following which we will have a panel discussion. Our speakers for today are Dr. Avishek Agrawal. He's a pediatrician from Jharkhand, followed by Dr. Anshum, Aneja, Arora. She's a pulmonologist from Gurugram, Haryana. Following their talks, we will have the panel discussion. For the panel discussion, we have Dr. Suba Jothi Kumar, who's an ENT surgeon. He's a NEET expert from Tirunelveli, Tamil Nadu. And we have Dr. Narayan Shah. He is the first CCI member who's abroad. He is from Nepal. He's a pulmonologist, practicing pulmonologist and a physician from Nepal. And we have Dr. Chalamaiah, who is a pulmonologist and critical care specialist from Kurnool. So following their talks, we will have a panel discussion.
Good evening, everyone. Myself, Dr. Avishek Agrawal, MD Pediatrics. I'm here to discuss about evolution of antihistaminic in pediatrics. As Anshum has already briefed us about the introduction, classification, and mechanism of action of antihistaminic, I would like to focus on the use of antihistaminic in pediatrics in brief. So, antihistamines are currently one of the most commonly administered drugs in children. Histamine is one of the most important mediator of allergy, inflammation, anaphylaxis, and gastric acid secretion. Antihistamines are mainly used to provide symptomatic relief. They do not cure illness, as they do not affect the underlying cause. Antihistamine competitively inhibit the action of histamine by blocking its attachment to histamine receptor, inhibiting the enzymatic effect of histidine decarboxylase, or catalyzing the transformation of histidine into histamine. So, basically, antihistamines are classified as first generation, second generation, and third generation. First generation mainly sedating antihistamine, including chlorpheniramine, diphenhydramine, promethazine, and hydroxyzine. The newer antihistamine, which include the second generation, relatively non-sedating, including terfenadine, estomazole, loratadine, cetirizine, and ketotifen, topical agilastine, and olaptadine. Of these, the first two were discovered first, and use of both were discontinued due to toxicity. Third generation, including fexofenadine, disloratadine, levocetirizine. Third generation antihistaminic are active metabolite of second generation drugs, developed with the goal of improving clinical efficacy and minimizing side effects. So, in clinical practice, antihistaminics are commonly prescribed off-label, especially in children younger than 2 years of age. In this case, there is lack of data on drug safety, and many antihistamines are not recommended. The main indication of antihistamines is the relief of allergic symptoms, which depend on histamine release, such as itching, sneezing, rhinorrhea, and congestion. A study done by Church et al. Demonstrated that the treatment of second generation antihistamines in children with allergic rhinitis did not lead to reduction in school performance. Although oral decongestant are recommended in children due to their systemic side effects, such as oral decongestion are not recommended in children due to their systemic side effects, such as irritability, dizziness, headache, tremor, insomnia, tachycardia, and hypertension. To relieve nasal congestion, topical decongestion are very effective, but rebound congestion can occur as vasoconstrictive action of this agent decreases. Due to downregulation of alpha-adrenergic receptor, topical decongestion usually should generally be used for about 3 days and stop, not more than that in pediatric. So, causal and contraindication of antihistamines in pediatric patient mainly is antihistamines should be used with caution children with epilepsy. First generation H1 antagonists are known to occasionally provoke convulsion in healthy children as well as epileptic patients. So, we must be very much cautious. Most antihistaminics should be avoided in acute porphyria, but chlorpheniramine, disloratadine, fexofenadine, ketotifen, loratadine, and promethazine are thought to be safe in this condition. So we can use it safely. Sedating antihistaminic inhibit the effect of histaminic not only in peripheral but also in the CNS, and additionally have potent antimuscarinic, anti-alpha-adrenergic, anti-serotonin effect, leading to symptoms such as visual disturbance, mydriasis, photophobia, diplopia, dry mouth, tachycardia, constipation, urinary retention, agitation, and confusion. They should not be used in neonate and should be used with caution in children with urinary retention, glaucoma, or pylorodenal obstruction. As we discussed above, that it too can cause urinary retention, dry mouth, and diplopia and mydriasis. So, sedating antihistaminics such as promethazine should not be given to children under the age of 2 years, except on specialist advice. Ventricular arrhythmia, as we all know, torsades de pointes, is commonly reported with estimazole than with terfenadine. Some antihistaminic, particularly abestine and mesolastine, can cause significant prolongation of QT interval on echo, which can cause severe and even fatal arrhythmia. Cetirizine is only second generation antihistaminic which is considered to be safe for the heart. Theoretically, fexofenadine is said to be cardio-safe active metabolite of terfenadine, but from the field experience, fexofenadine still causes QT prolongation, interval lengthening, life-threatening arrhythmia in patient with mild hypertension or mild left ventricular hypertension. So it's better to avoid it until unless not needed or at most needed. Disloratadine is cardio-safe form of loratadine. First generation antihistamine are considered to safe to use during pregnancy. All antihistaminic are considered safe to use during breastfeeding, as minimal amount are excreted in the breast milk and would not cause any adverse effect on breastfeeding infant. Drug interaction of antihistaminic in pediatric and in general also, second generation antihistamines could interact with several macrolide and ketoconazole. This effect is due to CYP3A4 inhibitor effect. So it is better if macrolide antibiotic are not given concomitantly with second generation antihistaminic in patient with history of heart disease, liver disease, and electrolytic problems. Thank you very much.
Good evening, everyone. Thank you, respected moderator, for the kind introduction. And at the outset, thank you to the CCI family for having me on board for this very important topic today, antihistamines. Now, antihistamines, as we all know, are one of the most used and one of the most abused medicines that are available over the counter. We can confess that all of us have used antihistamines in our prescriptions all through respiratory disorders, actually. And there are so many patients who take antihistamines on a regular basis that it's important to understand the background of these medicines and to understand and revisit the pharmacology of this medicine before prescribing the newer medicines that are available. The allergic diseases are really on the rise, and for antihistamines, it is so important to stay updated. So what are antihistamines? Antihistamines are those drugs which treat histamine-mediated conditions. Now, are they histamine antagonist? No, they are actually inverse agonists of histamine. So they were never intended to block the same site where histamine is binding to the receptor, but they act at a different ligand. Histamine receptors are of 4 types, H1, 2, 3, and 4. And what is of more interest to us at pulmonologists is histamine receptor 1. This is the receptor which is present on smooth muscles, endothelial cells, and also in the CNS. And this is the one which is involved in allergic diseases. The receptor 2 is present more in the gastric parietal cells, so it relates a lot to gastric acid secretion. And histamine receptors 3 have a neurotransmitter role, with histamine 4 being more of immunomodulatory role. So it is the H1 receptor that really involves a lot around allergies and allergic disorders. Now, this is how the histamine receptor looks like. It is a G protein coupled receptor. It is like a cellular on and off switch. So this switch is usually in an off mechanism, in an off conformation. And when the histamine comes and binds to this switch, it turns the switch to on. And that is how the inflammatory cascade starts. Now, if you look at this diagram, you'll see that histamine actually binds to 2 different ligands on the histamine receptor. and antihistamines bind on a different ligand. So this is why the term inverse agonist, because although the ligands where histamine and antihistamine bind are different, yet antihistamines can switch off the switch which was switched on by histamine. Histamine, we all know, is one of the major mediator of inflammatory reaction in both early and late phase. And it is once the allergen is presented and taken up by the antigen-presenting cell to the T helper lymphocytes and the B lymphocytes that IgE prime cells relate the histamine release. So this release of histamine, which causes not only increased capillary permeability, increased blood flow, extravasation of leukocytes and fluid into the tissues, if we are able to work against this histamine, we are able to stop the cascade of the inflammatory reactions. Thus, the clinical implications of antihistamine revolve more around allergic disorders. Of these, there is a very strong evidence of the use of antihistamines for allergic rhinitis, allergic conjunctivitis, and skin-related allergic disorders. The role of histamine and antihistamine receptors in asthma or upper respiratory tract infections, sinusitis, nasal polyps, or cough, which is not of any known origin, is also utilized by a lot of us in our prescriptions. But there is a weak evidence base for the use of these drugs in pure asthma or pure respiratory infection, as we know. There's also a very weak evidence for the use of these drugs for off-label use, which is seen sometimes, mostly around the older generation antihistamines. We see a lot of patients using it as sedatives. Sometimes it's also used for insomniac patients. It may also be used for motion sickness. So the clinical implication really evidence-based revolves around mostly the three allergic conditions that I mentioned. Antihistamines are classified into two main categories, the first generation antihistamines and the second generation antihistamines. The first generation antihistamines, as we know, are highly non-selective. So they not only work on histaminic receptors, they also work on dopaminergic, adrenergic, muscarinic receptors. And so the side effects that they ensue are multifold. They're also highly lipophilic, and they can cross the blood-brain barrier so easily that sedation is a very big problem that can arise out of these medicines. They're not only cardiotoxic, hepatotoxic, but they have a lot of drug-drug interactions because of the metabolism in liver by cytochrome P450 system. In contrast, the newer antihistaminics that we now have, or the second generation ones, are more selective. So they just act on H1 receptors. They are more therapeutic index, they are less lipophilic, they cause minimal or very low sedation, and they have less drug interactions. So these medicines can be used more safely in more patient population, including adults and pediatric as well. So talking about the evolution of the first and second generation antihistaminics, this beautiful picture shows us how the antihistaminic drugs came into being. It was in 1937 and 40s when Storm and Bovett accidentally thought of the idea that since cholinergic compounds, dopaminergic, muscarinic, and adrenergic act more on the similar lines, so antihistamines can be produced from similar drugs like anticholinergics. Slowly came the evolution of drugs like chlorpheniramine, promethazine, terfenadine, which were all having cholinergic activity also, but they were highly sedative. It was only 1980s and beyond that cetirizine, one of our most prescribed antihistaminic drug, came into being along with loratadine, followed by Ebastin and fexofenadine. Now we have some newer drugs which have come in the 20th century, and they can be sometimes also called as third generation antihistaminics. These, like desloratadine, levocetirizine, are either enantiomers of pure cetirizine loratadine, and rupatadine and belastin, which are the newest kids on the block. So antihistamines that we know of, like brompheniramine, chlorpheniramine, promethazine, meclizine, cyproheptadine, so many of those we see in our cough syrups and off-label cold medications, mostly belong to the first generation antihistaminics. And the second generation antihistaminics involve cetirizine, levocetirizine, Belastin, desloratadine, Ebastin, and fexofenadine that we use. There are also topical antihistamines of the second generation like azilastin, which we highly use in nasal sprays, imidastin and epinastin, some of them being used for topical ocular preparations. Since the side effects related to first generation antihistamines are manifold, the search for the ideal antihistamine is still on. And that is why more and more antihistaminic drugs are coming into being. We would want a drug which has the smallest possible sedative effect, a very high therapeutic index, beneficial pharmacology, and the drug which does not interact with many other medicines. In this search, a lot of new antihistamines, as I said, have come into being. And now we're also having a lot of combinations available, such as ones with leukotriene antagonists, decongestants, even analgesics, intranasal steroids, and intranasal antihistamines. By the end of this panel discussion, we hope to discuss more about these combinations so that we have a clearer picture of which and when to use. The current status of antihistamines is though revolving around the acceptability of second generation antihistaminics in all global and local guidelines. The allergic rhinitis and its impact on asthma guidelines, which discuss allergic rhinitis with asthma, also place second generation H1 antihistaminics on the first place. First generation antihistaminics should be avoided wherever possible, with special regard to pediatric population where they are actually contraindicated below 6 years of age. Thank you, and we'll follow with the panel discussion.
Thank you, Dr. Anshum and Dr. Avishek, for a wonderful presentation. You've given us a lot of insights on antihistamines. You made a lot of, what is basically how antihistamines, at what time it was started off. All those things were done. You put it on record very well. Now we will go for a panel discussion. We'll try to learn more about these antihistamines in the panel discussion. So we have our ENT specialist. Our first question to Dr. Suba, Jothi, Kumar. Can you comment on the rationale of using antihistamine over the counter by all general practitioners for common cold?
See, this has become a very habit of every general practitioner. See, every patient coming with a common cold, they add on an antihistamine, thinking that it will help the patient. The thing is that antihistamines are targeted against the histamine activities in the body. For example, if an acute inflammation is happening in the body, only during the acute inflammation, this antihistamines will work. So what is basically a common cold? The patient will be having a nasal stuffiness. The patient will be having some productive cough. For that, you need more than of an expectorant or an antitussive rather than an antihistamine. This habit of prescribing antihistamine for every common cold patient is not a very promising practice that is being common. You can do for initial 2 days, but after that, it's not very advisable.
Thank you, Doctor. The next question we have to Dr. Narayan Shah. He's from Kathmandu, Nepal, because he's in a hilly region. The question what I would like to ask to him is effect of 2 or more antihistamine components at 3 different altitudes, at the terrain level, at the hilly region and the mountains. Dr. Narayan Shah, please.
First of all, thank you very much, sir. First of all, I would like to thank the trustee chairman, Dr. N.S. Krishna sir and Narayana Pradeep. And also I would like to express my special gratitude to National President, Dr. Ashish Dubey and National Secretary, Dr. Anil Maske. Thank you very much for this opportunity, sir. And I'm going through the question now, sir. Yeah, obviously, I am here. I have been practicing here in Kathmandu for the last 2 decades here in Kathmandu, and I have encountered so many. For example, the patient come from the Tarai regions, hilly regions, and from the Himalayas. Obviously, we have got the problem with the allergic reaction or the allergic rhinitis or the bronchial asthma, and there is the triggering factors. But I thought that different altitude, patient coming from the different altitude, the problem is that they have got the triggering factor, different triggering factors. For example, people coming from the Himalayas, they are suffering from the cold allergy, and from the Tarai region, they are having the problem with the allergic rhinitis or the allergic rhinosinusitis. These are the some common precipitating factors. Then yes, obviously altitude is not going to change the antihistaminic. We have to give them, but the thing is that we have to give them the same antihistamines, and we have to sometimes we have to add on the expectorant and mix of antihistamines.
Okay. We've been using oral leukotriene receptor antagonist with antihistamine. There are a lot of combination available in the market now. This is for Dr. Chalamaiah. Can you please highlight on the role of oral leukotriene receptor antagonist and antihistamine in both allergic rhinitis and asthma?
First, to come to the component of allergic rhinitis. Allergic rhinitis, actually the role of antihistamines is antihistamine itself is limited. It's not the first choice. When we go through the maintenance therapy of allergic rhinitis, the drug of choice will be a glucocorticoid. And if the patient is not, if the patient is having only mild symptoms, then we can try antihistamines. That too, nasal antihistamines are preferable when compared to oral antihistamines. And the combination of oral leukotriene antagonist and with antihistamine is not recommended for allergic rhinitis per se. If the patient has a concomitant asthma, we all know that leukotriene receptor antagonists have a role to play in pathophysiology of asthma. In patients where there is a mild asthma symptoms, and the patients whose preference is not for the inhalers are the patients who are apprehensive about the usage of glucocorticoid spray inhalers. So there we can go with leukotriene receptor antagonist plus antihistamine combination. Otherwise, only patients having allergic rhinitis, it's preferable using an antihistamine or a glucocorticoid nasal spray rather than using oral leukotriene antagonist and antihistamine combinations. Thank you.
Yeah, because we are using, most of us keep using oral leukotriene receptor antagonist for allergic rhinitis. I think so. You made a point very clear here that it is the antihistamine to be used. So, thank you, Dr. Chalamaiah. Now we have a question because Dr. Anshum has elaborately spoken on antihistamine. I would like to ask her, is there any direct role of antihistamine in viral upper respiratory tract infection, Dr. Anshum?
Yeah, thank you for the question, sir. So if we look at the mechanism of action, definitely antihistamine do not have any direct virucidal activity. So there is no direct role of antihistamine in any viral infection. Whatever benefit that symptomatically a patient will get will be some weak benefit secondary to H1 blockade. So symptoms of rhinorrhea or symptoms of sneezing or upper respiratory tract symptoms may be mildly reduced. However, role directly as an antiviral agent is not there. There have been, however, some studies, especially post-COVID, where H2 blockers like famotidine were used for COVID also. So after that, a lot of trials were set forth where drug repurposing is being tried and the role of antihistamines is being studied with regards to its anti-inflammatory role. So certain newer compounds like belastin have some role against IL-6 and IL-8. Rupatadine is supposed to have some role for platelet aggregating factor. So these compounds are being studied because of their anti-inflammatory role in management of viral diseases. But directly, there is no role.
Thank you. Thank you. I think so. We never knew about the role of antihistamines in viral infection. You made it very clear. But rupatadine is one time, probably in 2004, as you told, probably it was there. I don't think so. The availability is there now. It's probably not there. That's what I feel like.
Much less. Rupatadine is not easily available as much as others. Yeah.
Correct. Now, Dr. Avishek is a pediatrician. So in our practice also, we see a lot of children coming to us with common cold, allergic rhinitis and asthma. I would like to ask him, what is the role of antihistamine in treating otitis media, common cold and non-specific cough? Over to Dr. Avishek.
Yeah, thank you, sir, for the question. Sir, the thing in pediatric, there is no direct role in otitis media and allergic rhinitis in the patient with antihistamine. Although we have to, in pediatric, we must have to see for risk is to benefit ratio also. So in pediatric patient, any day antihistaminic, as I discussed earlier, was not actually recommended in general. So it's better to avoid until unless it was proven that there is any role. It is irrational to use in common cold and rhinitis in pediatric also.
So what do you suggest in case you want to use an antihistamine? What would be your preferred antihistamine?
Yeah, if I'm suggesting, then it's all basically to give reassurance, to give some home remedies like warm water or feed fluid which were hot, like we can advise them for khichdi, rab, dalia, like this, which can also soothe the respiratory tract and help the baby also. But not as just we go for medication. The reassurance was the major treatment for the baby.
Up to what age you would not like to use? Probably say after 5 years, can it be used?
Yeah, it can be used after 2 years of age. Okay, I'm okay with after 2 years of age, but definitely I will avoid till 5 years of age if it is possible. Until it's not it's utmost important indication.
In continuation, is there any rationale behind a combination of antihistamine with the drugs in the pediatric age group?
No, actually there is no rationale between beside using antihistaminic and combination of drug, because in pediatric there is always a dose combination which matter, and there is always we give in a drug which were distributed in the body. So there is always by weight or by body surface area we give medication. So if we combine some drug, there is different composition. So after giving, if there is any combination like paracetamol, phenylephrine, what were generally used, dextromethorphan. So if you are considering one drug like phenylephrine or paracetamol as a drug to calculate the doses, then other two drugs will not match with that drug most of the time. So it was not rational to use it. It's better to avoid. It's better to use single drug combination. If you want to give paracetamol, give it alone with cetirizine, with anything, but you can give it separately so that you can titrate the drug doses and the weight by the weight of the baby or body mass index.
Thank you, Dr. Avishek.
Thank you,
moving on, next question to Dr. Anshum. Can you tell us about what you have observed, commonly observed side effects of the first generation antihistamine that you see in your practice, and how does it affect your patient selection?
Okay. So, mostly the first generation antihistamines that we are encountering now, patients are taking in the form of syrups. So, because less and less number of practitioners are also using oral tablets for first generation. And most of the patients that are coming back taking these will complain of sedation. They complain of dizziness. They also complain of headache, which lingers on even up till the next day after consuming the syrups. A lot of patients are overdosing themselves and they are taking multiple teaspoons without the recommended dose. So a lot of these side effects are arising because of overdosage or disproportionate use. Also, what we see is that if patients have been on first generation antihistaminics for a long time, then sometimes they do not realize that the sedation or the dizziness is there, but their reaction time reduces. So the quality, it has a qualitative effect on patient's performance, and his psychomotor performance is affected. So keeping all these things in mind, if I were to prescribe a first generation antihistamine to someone, I would like to avoid patients who are working in such situations where there could be a risk of accident. So like drivers, pilots, also in children, because it affects their school performance. And again, in elderly, because we know that they could have falls secondary to it, and patients where they have a lot of interactions, the patients on polypharmacy. So again, elderly, because first generation antihistaminics have the maximum drug-drug interactions. So I would select patients which are out of this basket.
So what would be the duration you'd like to give in case they come to you with a specific problem?
Yeah, so first generation antihistaminics, those should not be prescribed unless second generation is not available, but they should not be given for a prolonged time. So usually 5 to 7 days till the presence of the symptoms should be more than enough. Most data available is on their efficacy in the first 2-3 days of any common cold illness. So it should not be prolonged. So I would preferably give it not more than a week if possible.
Okay, given an option, is there any side effect for the second and third generation that you have already spoken about?
Yes, so second and third generation have much less sedation, which is their one plus advantage definitely. But still, patients do complain of headaches. The second thing is there's a lot of dryness also associated. So most of second generation antihistaminics will cause some xerostomia, and patients also complain of abdominal pain. A lot of times I've actually had patients who were taking fexofenadine and came back saying that it has caused abdominal pain, although I'm not sure of the mechanism how it happens. But yes, mostly headaches, dryness of mouth, and some patients also complain of abdominal pain.
Thank you, Dr. Anshum.
Thank you.
Coming back to our Dr. Chalamaiah, can you please tell us on the combination of glucocorticoids and antihistamine in managing allergic rhinitis? You already told. I want you to be more specific on this.
Yes. As we have discussed already, the oral nasal glucocorticoid combinations are the first line of management in the maintenance treatment of allergic rhinitis. So the role of nasal glucocorticoid plus antihistamine combination comes when the patient is a patient of allergic rhinitis is having persistent symptoms even on maintenance treatment of glucocorticoid spray. And if the patient's symptoms are moderate to severe, then we can consider this combination. The commonly available combination is agelastin and fluticasone combination, which is easily available, but it should not be used for a prolonged duration. Once the patient's symptoms are under control, we need to switch back to our nasal glucocorticoid combination rather than using along with antihistamine combination. It's only a patient who is uncontrolled symptoms only we need to use this combination. Otherwise, it's not routinely recommended to use this combination.
Okay, thank you. One common question is asked. This is to Dr. Narayan Shah. Most of our patients who are both allergic and asthmatic, they come to us, especially the alcoholics. They come to us. They will ask us questions regarding, can I take alcohol? Can you highlight Dr. Narayan Shah regarding allergic and asthmatic reaction to any alcoholic drinks?
Yes, sir. It is a really very interesting question once again. And the same type of patient we are encountering here in Nepal also, sir. Basically, what happens, sir, regarding the alcohol, we everybody knows it has been divided wine, beer, and as whiskey or brandy, something like that. Yeah, obviously the preservatives added in the wines or beer, it really affects the asthmatic patient. So that these are the especially we found that patient or people drinking wine or beer, they have got some triggering factors as sulfides, so that it may worse the symptom. So that I recommend personally not to take the alcohol or any drinks. Though there are so many words that sometimes people say that brandy or whiskey, it's helping us very nice, but actually it is not going to help. Rather than it is going to give a different scenario, that it may give the thickening of the mucus and worsen the symptoms. So that I would like to say that no, absolutely no to alcohol.
This is a very common question asked by our patients. So you have clarified it very clearly that there is no alcohol. That's very clear. Thank you.
Can I answer? So
Yes.
I think because the sedation effect is also one thing which is common between alcohol and antihistamine. So it is just gonna make it even more. And if a patient overdoses an antihistamine, then sedation in presence of alcohol will be much more. So
Correct,
that's all.
correct. Thank you, thank you. Moving on, coming back to our ENT specialist, Dr. Suba Jothi. Can you justify the usage of topical antihistamine or oral antihistamine drugs and their pros and cons about it?
So basically, as evolution of antihistamines goes, we found out the second generation, then third generation. We have minimized the adverse effects to maximum extent as possible. As of allergic rhinitis, we ENT people is concerned, our main thing is total nasal symptom score. We have 5 symptoms out of it, right? Rhinorrhea, nasal congestion, like that. So we want people, we want patients to relieve from that total nasal symptom score, those 5 symptoms. If we consider all 5 symptoms, oral and the intranasal may be equal. But if we consider a patient with more of rhinorrhea than of other symptoms, and intranasal, that is azilazine fluticasone combination, is preferred more than the other combinations. So based on the symptom, so if you have a more of rhinorrhea symptoms, you can go for an intranasal based antihistamine combination rather than oral antihistamine combination. So that's the answer for that particular question. So let me also answer a few of the questions from the audience. So I could see two other people asking the same question. Maximum duration of antihistamines for severe allergic rhinitis patient. Then what minimum and maximum duration can we discuss? First of all, for allergic rhinitis, you divide the allergic rhinitis into 2 groups. Only one is mild group, second is moderate to severe group. If it is mild group, the symptoms are very meager. It will come once in a while. But if it is a moderate to severe group, the symptoms occurs at least 4 days a week, and at least more than 4 weeks duration, it will be there. If the duration matches like this, and the patient is having disturbed sleep, and the patient is having loss of concentration at work, it is affecting the normal routine activities of the patient, you brand him as moderate to severe group. So that first you classify the group which the patient presents. Then you started prescribing. If the patient is having a mild group, you start giving only oral antihistamine plain or oral antihistamine with some leukotriene antagonist. Then if the patient is having fall into moderate to severe group, then you can switch to the second combination. You can go for an intranasal antihistamine. Okay. Or else you can also add intranasal antihistamine with intranasal steroid. Okay. You give that antihistamine, you give that steroid for at least 2 to 4 weeks. You review the patient after 2 to 4 weeks. Again, the patient says that, no doctor, despite all your treatment, I'm still having this particular symptom. You again upgrade the treatment. You try to add some oral steroids if needed. If the symptoms are very severe, you try to add an oral steroid. If still doesn't work, so final resort that is available now is immunotherapy. Immunotherapy is a booming thing in allergic rhinitis. It could definitely help the patient. You find out the allergen with skin patch test. You find out which allergen is causing an allergic rhinitis. That could definitely help your patient with long-standing allergy rhinitis, you don't prescribe oral antihistamines for 2 months, 3 months, never. Maximum you give for at least 2 to 4 weeks. If the patient doesn't improve with the symptoms, you switch over to the next line of management. If that still doesn't work, you switch over to the upgraded management. This is how it works. You please don't prescribe for a longer duration of time. That will end up the patient having the side effects and adverse effects of the antihistamine.
Thank you, Dr. Suba. Coming back again, can you tell what is the latest discovered antihistamine drug and what are the major advantages of using it?
As Dr. Anshum said, the recent and latest antihistamine drug was Bilastine. It was discovered 2010 and was commercialized by 2015. The major thing, as far as ENT consultants considers, Bilastine is like quite a good drug, quite a better drug compared to other antihistamines, because the first thing is it is least sedative. Second thing is the T-off is very higher compared to the previous thing like Suba or Ipastine. The T-off is very higher, and we can give the alertness and concentration quotient of the patients are also better compared with other antihistamines. So if an IT guy coming to me, I will give this antihistamine. He is having this episode throughout the work, even during the morning time, afternoon time. I ask him, take this Bilastine 1 hour before food or 1 hour after food. It will be helpful. You will not get symptoms of the allergic rhinitis throughout the day. That is helping him to greater extent. So these sort of patients, I will not ask them to take every day. If they are having that allergic episode, if they are having very exacerbation of the symptoms, I ask them to take a Bilastine. So according to my practice, Bilastine is a better drug. It is having lesser side effects. It is having lesser sedation compared to other antihistamine. So that was about the Bilastine combination.
Okay. Thank you for updating on Bilastine part. We've been using in asthmatics both theophylline and anti-allergic drugs. Now, I'd like to ask Dr. Narayan Shah, what is the interaction between theophylline and anti-allergic drugs and the efficacy and safety of non-brain penetrating H1 antihistamine for the treatment of allergies?
Thank you very much, sir, once again. Obviously, the theophylline we use as a bronchodilator, and it has got its anti-inflammatory properties. We all know it. Though what happens in the allergic rhinitis, we can use it with the theophylline, but there is no significant improvement in allergic rhinitis in comparison, unless until it is associated with the lower respiratory tract infection. Also means the bronchial, once there is persistent asthma or there is allergic rhinitis in patient is having bronchial problem also, then yes, obviously there is some it is going to help to those patients, but only for the upper respiratory tract infection, I don't think theophylline is in good benefit for it. And the second thing that you mentioned, sir, that non-brain penetrating antihistamine. Obviously, the second generation antihistamines, as Dr. Anshum already everything in her slide, the second antihistamine is more better, and the third generation, that is the non-brain penetration, that is the desloratadine and the fexofenadine. So that it is these drugs are much more less. These drugs are much more safety, and we can use in all circumstances. So we are having using the levocetirizine or fexofenadine or desloratadine in the current scenario in bronchial asthma or allergic.
Thank you. We have a lot of comorbid conditions, especially using antihistamines. I would like to ask Dr. Chalamaiah, what is the safety and dosing of antihistamine in renal disease?
As we all know by now, the second generation antihistamines are the favorite drugs in kidney comorbid condition patients. And among the second generation antihistamines also, most of the times we need to dose modify our drugs according to the drug we are using. We need to do a renal modification for most of the drugs, except for the newer antihistamine, Bilastine and desloratadine, which are also third generation antihistamines. There is no need to dose modify them. And even our commonly used cetirizine and levocetirizine also need to be dose modified in patients with creatinine clearance of less than 30. So we should be careful regarding the dosing in these patients. Otherwise, we may see more sedative effects and myalgias, headaches, and tremors in these patients. So we should be cautious regarding that. They are safe. All antihistamines can be given. Second generation antihistamines can be given in renal patients, but we need to dose modify them safely.
Even in a dialysis patient who's undergoing dialysis, is it the same?
Yes, definitely. Even the dialysis and end-stage renal disease whom creatinine clearance is less than 10, most of the antihistamines, second generation antihistamines can be given. If you say, for example, cetirizine, it should be given. It should be given at a 5 mg dose alternate day. It should not be given regularly. So, according to levocetirizine, if you take a hemodialysis patient, it should be given 2.5 mg alternate day. So it's not in the regular doses, and we should be especially careful while giving it in a combination dose where we cannot decrease the dose of antihistamines, because we are of a common practice of giving leukotriene receptor antagonists along with antihistamines. So those will be dangerous in these renal cases. In those cases, we need to favor, if the patient is having asthma plus you need to give an antihistamine, that patient is an end-stage renal disease, we need to favor newer antihistamines like bilastine and desloratadine rather than going with cetirizine and levocetirizine and avastin drugs.
Even leukotriene receptor antagonist also should be avoided.
Renal modification dose is not needed for kidney patients when we talk about leukotriene receptor antagonists, but as we said, it's not to be abused, because there is an US box warning also regarding the same thing. Neuropsychiatric effects are very significant. The side effects have been occurring with the use of montelukast. So it's they expect us to the branding is more regarding the montelukast thing. So we should be cautious while advising whether my patient does it really benefit my patient by giving montelukast, or it is going to do more harm. We need to decide before prescribing it.
Thank you, Dr. Chalamaiah, for a nice update. Coming back to Dr. Anshum, can you tell us what are the cardiovascular safety concerns behind the antihistamine? You have mentioned in your talk. We would like to listen to more on these.
So cardiovascular safety concerns mostly revolve around, again, the first generation antihistamines more than the second generation ones. In fact, the newest antihistamines like bilastine, desloratadine, they have been found to be highly safe in cardiac patients. And there have even been reports of higher doses of bilastine, even up to 3 to 4 times, being given in cardiovascular patients, in patients with CAD, and was still found to be safe as much as placebo. So the newer antihistamines are actually quite safe in cardiovascular disease. The problem arises mostly with the first generation, mostly around astimazole and terfenadine. And that's how the concerns about cardiovascular safety came into being, because they were known to cause paucity pointis and ventricular arrhythmias. So, but I would like to clarify that it's not a class effect. So all antihistamines do not cause ventricular arrhythmias. They do not cause prolongation of QT interval. Even up to fexofenadine, QT interval prolongation has been seen, but most of them, patients either in overdosage or patients with underlying hepatic diseases, patients with slow acetylator status or metabolism being delayed, or patients who are taking multiple drugs with drug interaction, their concerns of ventricular arrhythmia are there. But the newest antihistamines are quite safe in this group of population.
Even with combination, they're safe to be used?
So combination, there are not enough data. So if you're talking about leukotriene antagonist and say desloratadine or bilastine, there's still not enough data. There are no robust studies. So I think as the previous doctor also said, that we need to be careful in chronic patients when we are giving combination. But solely, yes, antihistamine, the newer one, are supposed to be much, much safer. So they can be given if there is an indication to give in these patients.
Because only in India, I think so, we have a combination. Leukotriene receptor with all antihistamine combination, I think so, it's only in India.
Yes.
Outside India, we don't have this combination. So our usage with the leukotriene receptor antagonists are more. So we come across patients with cardiovascular diseases, we come across patients with renal diseases, we come across patients with CNS. So I think so we need to work on this and find out how the combination works.
Yes, and so the combination studies with the newer agents are also not very robust. So if you look at the studies, there'll be data of say 80 patients or 50 patients. Such studies are more than properly conducted RCTs. So we still have to look at these combinations in at least comorbid conditions. Individually, these drugs have shown with test of time that they are effective.
Correct. Thank you, Dr. Anshum. Again, coming back to Dr. Avishek, we see a lot of pediatric patients. Can you tell us the duration of antihistamine to be prescribed in a pediatric patients?
Yes, sir. Sir, actually, if we are giving for, as I mentioned, antihistamine only gives symptomatic relief, not treat the cause. So it must be very much time bounded. We have to give for 3 to 5 days, and then we review the patient. If everything is okay and if the symptomatic relief has been achieved, then it's better to stop the antihistaminic rather than to continuing it for 10 to 15 days. Yeah, in short, we can give, if not 3 days, if possible, then we can give to for 1 week, not more than 1 week. Okay, and we must keep a review for that. After giving that, we must know what are the how patient responded or not. If patient is responding and is responded well, we must stop the antihistamine.
Okay, fine. Well, when you prescribe a child on antihistamine, what advice you'd like to give to the parents?
Yeah, for parent, we must acknowledge them what are the side effects, because what we said, each action has equal and opposite ways. So every drug comes with some adverse effects. So like when we are prescribing antihistaminic, we must acknowledge them with the dryness of eye, constipation, urinary retention, dizziness, and sometimes irritability, what also come across in clinical practice. The patient become irritable after taking this. We must give them advice. It's better to avoid. If the child was going for swimming, and if child have any epilepsy, then we must let them know there is a risk for increasing epilepsy, and in swimming there must be chance of drowsiness. So it's better to avoid if we are giving that in the children pediatric age.
Epilepsy is a concern.
Yeah, any day epilepsy, convulsion, and they are actually the thing which are normal to the baby. Epilepsy, cardiovascular system, and main thing is drowsiness and dizziness, which make child very much irritable. If child over lesser than 3 years, 5 years, then they become very much irritable and dizziness. So parent doesn't recognize it. Okay, this is because of drug, and they will think okay, it's because of patient was improving, baby is improving. It was not like that. Actually, baby become drowsy, so they must consult some doctor.
Correct. Yeah, this is a very good important point what you are told. Thank you, Dr. Abhishek.
Thank you.
Coming back to Dr. Anshum, which antihistamine can be safely prescribed in pregnancy and lactation? We keep seeing patients, pregnant ladies who come to us with asthma and allergic rhinitis, both pregnancy and lactation. So, which antihistamine can be safely prescribed?
So first of all, sir, there is no single antihistamine which is absolutely safe in pregnancy, and no antihistamine so far has received category A of usage approval in pregnancy. So whatever drugs we have, amongst those, mostly the first generation. So this is one of the very limited role or indication of first generation antihistamines are being preferred over second in this group. So pregnant females, if we want to give antihistamine, we should prefer the first generation for a very short interval, obviously, until the symptoms subside, over the second generation ones, mainly because the second generation studies and data is still not there for safety. The data is mostly around the first generation in regards to teratogenicity, and so these are approved even by FDA, and so we can prefer chlorpheniramine in such patients, or we can prefer promethazine here. And secondly, in lactation, there is some secretion of the antihistamine in breast milk. Almost around 0.1% is expected expected to be secreted. So I think Dr. Avishek will be able to clarify that further, but there is patient must know that it will reach the baby also. But if we have to prescribe, first generation would be preferred. Cetirizine is also safe comparatively as compared to the newer ones, and there is also some safety around loratadine. Again, desloratadine is not as safe as loratadine in pregnancy. So first generation, cetirizine and loratadine. And I would like to add that I see a lot of gynecologists giving Montelukast freely nowadays to pregnant females, which was not being done earlier. So again, Montelukast is also in category C. Still, we do not have enough human data on its safety. So
is there any, like, first trimester, second trimester, third trimester antihistamines for a safer use?
So yes, so third trimester, it's still safer to use antihistamines because organogenesis has already occurred. So second and third would be better. First trimester, we have to be extremely careful. But any day, my personal preference, I usually give cetirizine mostly, because we know that again, syrups can cause a lot of sedation and also. But Montelukast is something which I see very commonly gynecologists giving it, and I mostly cut it off in my prescriptions. So I think that should be discouraged.
Yes, you are right. Montelukast should not be given. It's basically contraindicated throughout pregnancy. Even what we have seen is Montelukast usage is after 5 years, even in the pediatric. Probably Dr. Avishek would be a better person to answer that. So during pregnancy, I would say it should not be used. So treat symptomatically with levocetirizine. That would be a better cetirizine. Probably cetirizine would be a better answer. Thank you, Dr. Anshum.
Thank you, sir.
Coming back again to Dr. Chalamaiah, can you tell us about the CNS safety of the second generation antihistamines?
As we have gone through the previous discussion, the second generation antihistamines are relatively has less CNS toxicity when compared to the first generation antihistamines, but they are not totally, it's not like they do not have CNS toxicity at all. So we should be careful while prescribing them. And most of these drugs, including the bilastine, desloratadine, whatever we think they are safe enough, can still cause some 4 to 5% chances of drowsiness, fatigability, irritability, and insomnia in some of the patients also. And the most common complaint what we see in day-to-day practice with this second generation antihistamines is headache. Most of 8 to 10% of the patients, even with the bilastine or desloratadine, usually do complain of headache. And the practice of prescribing regularly prescribing antihistamines and leukotriene receptor antagonists in at least ICU patients and in sick patients, at least with acute exacerbations, should be discouraged. We all know that there is no role of using these drugs in acutely sick patients who are already in altered sensorium or because of septic encephalopathy or because of the underlying CO2 narcosis. So we should abstain ourselves from using these combinations or even newer antihistamines regularly in critically ill patients, as these all drugs do have CNS toxicity in a limited 4 to 5% or 5 to 10%. So we need to abstain from regularly using these drugs.
Yeah, along with the CNS toxicity, also in an acute setup, probably it causes the dryness of the airway.
Yes, definitely.
Again, it is contraindicated.
Urinary retention. There are multiple things.
Yeah.
Though the frequency is a little less common when compared to the first generation, definitely second generation antihistamines do have their side effects.
True. Yeah. Thank you, Dr. Chalamaiah. We are seeing dengue fever everywhere, even in India, in Kathmandu. So I'd like to ask Dr. Narayan Shah, at present, the pandemic of dengue fever in Kathmandu, what is the role of antihistamine? Can you highlight the role of antihistamine in dengue fever?
Yes, sir. We have got so many patients these days for dengue, and we often see that there is maculopapular rashes, all the body are itching, so that we often use the desloratadine or fexofenadine, and it is going to help. So that antihistamines has got the potent role in the dengue fever, sir. We have been using it, and we are doing we are getting the good response, sir.
Only in the rashes, papular rashes, or anywhere else it has been used in the dengue fever?
Yes, sir. Basically, what happens, the patient have got the low platelets counts and LFT has been deranged, SGOT-PT is deranged, and few of my cases that went to acute liver failure and pleural effusion, but they were well managed, and none of them died. One of my patients died due to hemorrhagic shock syndrome, and obviously it is a very terrific situation here in Kathmandu. For the few days, for the last 1 month, I think there was no hospital, no vacant place in hospital. There was one phase that during the COVID time, we don't have got the bed for to admit the patient, and now in last few months, we had the same situation, the dengue. All the hospitals bed are full of dengue and dengue. Till date, we are looking, I think, even though I am looking the 50 to 60 patients per day of the dengue. That's the situation. Nowadays, none other cases are appearing, only dengue. So that we see the dengue LFT deranged platelets 9,000, 10,000, 20,000, and hematocrit less than 20, 40, like that. And so that, yes, there are very difficult situation, but we are going to overcome it by soon. To antihistamine,
Okay.
we are going to, yes, and also we are giving the antihistamine, that is the desloratadine or the levocetirizine or fexofenadine. The second generation are doing good, sir.
Okay. Thank you. Thank you very much for the update on how you are using antihistamine in dengue fever. Going on to Dr. Suba, Jothi, Kumar, does any synergism exist between the combined usage of topical antihistamine along with topical steroids?
For this, I would like to quote 13 studies, randomized control trials, which was done for this particular question. So a meta-analysis quoting all the 13 RCT studies have been summarized. That meta-analysis shows that if you are using an intranasal steroid separately or oral antihistamine separately, or even an oral steroid separately, usage of intranasal steroid with intranasal topical antihistamine, mainly acylastine, has more better effects compared with the single treatment. So if you are having an allergic rhinitis, moderate to severe group, if you are going to, if the patient is coming back with persistent symptoms, you can try combination therapy rather than trying only single therapy. That's the answer for this particular question. I would also like to answer a question from audience.
Before that, how long it can be given? What is the duration of acylastine you would like to give to your patients?
I would like to give for if the patient is purely allergic rhinitis, I would like to give for maximum 3 to 4 weeks. If the patient is having an allergic rhinitis, not only allergic rhinitis, the patient is also having ethmoidal polyp, nasal polyposis, I would like to give the patient for at least 3 months. Then I will again review the patient, because nowadays I'm using not only steroid nasal spray, also combination spray that is having some synergistic effect. So for medical management sinusitis with polyposis as well as post-operative polyposis patient, I'm using this combination therapy only. It is having a better effect than my single steroid nasal spray.
Which steroid you would prefer, like in the combination?
I would like to prefer fluticasone furoate, sir.
Okay. So you want to give a combination for at least 3 months for polyps?
Yeah, I would like to give it for 3 months. If the patient is confirmed to be ethmoidal polyp, I would like to give them for a lifetime.
Oh, lifetime. Oh, you don't advise.
I will be expecting the recurrence. Sorry. I would be expecting recurrence anytime. Okay, so I would be giving that particular treatment for lifetime. So what is happening means, one patient is using only intranasal steroid the patient did not use steroid for 1 week. Another patient did not use this combination therapy for 1 week. So after 1 week, if I review both these patients, single treatment has recurrence. This combination therapy, the frequency of recurrence at least has been lengthened by this combination therapy. At least if the patient doesn't take steroid, this combination therapy for 10 days, it will not give recurrence. Whereas only steroid spray, if the patient is not taking for 1 week, the polyp will start budding from the nasal cavities. Shall I answer another question from the audience, sir?
Yes, please go ahead.
So as many of you are asking for the role of antihistamines in sinusitis. See, if you are having sinusitis, for example, with frontal headache, the maxillary headache, with case of nose pain, that is an acute sinusitis. In acute sinusitis, you can give an oral antihistamine. If there is some nasal symptoms like rhinorrhea, nasal congestion, nasal discharge, you could give an intranasal antihistamine. But if the patient is quoted as a chronic sinusitis, the antihistamine has no role, because there is already an established infection that is happening inside the paranasal sinuses. Your antihistamines for 1 month, 2 months is not going to help this chronic sinusitis pathophysiology in any way. So kindly don't use oral antihistamines for prolonged duration for chronic sinusitis. You may ask, then what is the treatment for chronic sinusitis? See, chronic sinusitis means the patient will be having obstructed osteometrial complexes. He will be having prolonged history, long-standing history of headache. You should take the CTPNS. You should find out at which level the obstruction is there. You should find out the level of the obstruction, whether it is medically treatable or it is surgically treatable. Medical treatable means if there is one, we are having 10 osteometrial units subdivided. If there is only obstruction at level of 1 or 2 units, you can give an intranasal steroid for 1 week. That is for only acute exacerbation. If the patient says that, doctor, I'm relieved of symptoms, you discontinue both the steroid as well as antihistamine, because you could treat medically only for acute sinusitis and acute exacerbation of chronic sinusitis. For chronic sinusitis, the treatment of choice is only surgery phase. Okay, so please, general practitioners, many have asked for this particular question. If you are having a patient coming to you again and again for chronic sinusitis, you can treat the acute exacerbation of chronic sinusitis. But the dragging sensation present for almost 2 or 3 months, you please refer to an ENT surgeon. That patient needs surgical advice. If not surgically corrected, the patient may end up getting a polyposis. And another question, interesting question they have asked for is, what is the role of macrolide antibiotics in chronic sinusitis? See, some 30 years back, there was a hypothesis that apart from the antibiotic role of macrolides, that is erythromycin, clarithromycin, azithromycin, they are also having some immunomodulator activity on chronic rhinosinusitis pathophysiology. That is improving the mucociliary clearance, reducing the goblet cell secretion. These are the immunomodulatory actions of macrolides. First, erythromycin was tried by Japanese. They thought that it has some effect. The antibiotic is not like routine dose of antibiotic, taken for at least 3 months to 1 year. The patient should take at least 3 months to 1 year to have this immunomodulatory effect. Erythromycin tried. Some studies says that it is effective. Then clarithromycin tried. Then azithromycin tried. But the thing is, if a patient is taking for 3 months to 1 year, he or she may get some cardiac side effects. The patient can get long QT, a prolonged QT syndrome. So this medical management for 3 months, first of all, if you are giving azithromycin for 1 year, the patient is first of all not affordable. You don't try that. You can try 250 milligram erythromycin, but still the safety profile of erythromycin is very, very bad. Okay, so please don't try. There are some studies, but recent studies never says that the role of macrolides in treating chronic rhinosinusitis are associated with allergy rhinitis. You don't give that. You better treat for the acute exacerbation. If it is not recovering, you take a CTPNS, refer to an ENT surgeon. Thank you.
Thank you. Very well. A lot of information you have given to us in managing both sinusitis and polyps. One last question to you. What is the food interaction and sleep interference of antihistamine drugs commonly used in your ENT practice?
As if I know, while I was a resident, I used, as in government setup, we would have only this cetirizine, levocetirizine, those kind of chlorpheniramine, those has more interaction. So usually we give those first generation antihistamines, which is widely available at government practice. We used to give that during night time. The patient will not complain, and those first generation and all don't have much interaction with food as far as I know. But this latest generation antihistamines, especially belastin, has interaction with the food. If you are going to prescribe belastin, you have to give belastin at least 1 hour before food or 1 hour after food. Either it is morning time or night time, it will have food interaction. It will reduce the bioavailability. It will reduce the absorption of belastin. So if you are going to prescribe belastin, kindly ask the patient never take with food. So as I know, other antihistamine doesn't have much food interaction, whereas the sleep interaction almost all the antihistamines have, except as far as I know, Avastin and belastin mostly they don't have sleep interference. They'll never affect the concentration of the patient as well. First generation, as previous speakers told, they are definitely having sleep interference. You should treat accordingly. I would like to answer one more question. What is the best antihistamine that you would love to give for any particular patient? See, there is no fixed criteria that you should give belastin, Avastin, or desclorpheniramine. See, as in my practice, if an affordable patient is coming to me, he is an IT guy. He wants concentration. He needs he can spend any amount of money. I will give belastin. If a poor patient is coming to me, he is having some acute exacerbation of sinusitis or he is having an allergic rhinitis, I would give only levocetirizine. Okay, if that is enough for that particular patient, considering the cost of that particular drug, I will give that only. There is no fixed rule that you should give only belastin, you should give only Avastin. So you just fluctuate yourself based on the clinical profile of the patient, based on the presentation of the patient, as well as cost effective analysis of the patient. Yes.
Thank you, Dr. Moving on, question to Dr. Narayan Shah. Can you tell us about what are the antifungal properties of antihistamine?
Oh, okay, sir. Yeah, obviously, I saw this one literature written by Dr. Walker that some histamine was some histamine antihistamine drugs have been tested for the fungostatic activity, and he used as a mycelial disc technique, so that to rule out whether there is some activity of antifungal activity or not. But again, when he tested this in the agar couplet method, then he found that each and every antihistamine was found to be triggering an inhibitory, and it was giving action. It was showing the properties of antifungal. So that yes, all the antihistamines product medicine, it shows the antifungal properties.
Can you tell us how it acts as an antifungal?
That Dr. Walker, scientist who tested the mycelial, he used the technique, that mycelial disc technique, to rule out whether that it has been the antifungal properties or not, and certain fungicidal medium, but it showed no inhibitory activity. But again, he tested in the agar couplet method, and it showed that yes, every antihistamine medicine showed the antifungal properties. Means each and every whether this one is the first generation or the second generation antihistamine or the third generation, it showed that according to the agar couplet method, it has been proven that yes, these have got the fungostatic properties.
Thank you. Now, having known that antihistamine has got some antifungal activity, Dr. Chalamaiah, can you tell us about what is the role of antihistamines used in non-allergic conditions? We've been using this as an anti-allergic. Is there any role in non-allergic conditions?
As our discussion was focused on all allergic diseases in allergic rhinitis, allergic asthma, and allergic conjunctivitis, dermatitis. We all know there is still a role for antihistamines in this condition. In non-allergic conditions like urticaria, both acute and chronic, and along with in cases of pruritus, there have been studies where these antihistamines can be useful. Already we had discussions regarding using it as in viral infections and common colds, and there is a supportive role in anaphylaxis. It's not a first line. We all know that anaphylaxis is first to be treated with adrenaline. There is no other drug which is effective in anaphylaxis, but still antihistamines have definitely a role, which have been being long used along with the glucocorticoids. Antihistamines have been used as a supportive care in anaphylaxis. And the first generation antihistamines, we know that they have the side effects which are anticholinergic and antimuscarinic side effects are there, which have been which help in their usage other than the allergic conditions, like commonly nausea and vomiting of pregnancy. We do use this dimenhydrinate and diphenhydramine in the nausea and vomiting of pregnancy. Though it's not the first line, it is usually as a second line drug. And during this morning motion sickness, in the motion sickness, most of the first line antihistamines are commonly used, including diphenhydramine and chlorpheniramine maleate can be used for this condition. And vertigo, also there have been multiple studies, including synergine can be used in these patients. And there have been some studies regarding even in Parkinsonism, potentiation of the effects of some drugs by giving an additional Avastin recently. But still, there is no profound data for these antihistamines as a role. As I said, it's the side effects which we are using to our advantage, and it's not commonly should not be used like a first line agent in most of these conditions. And with the promethazine, we can use it like a sedative. In these are some of the usage of the side effects of these drugs used as a first, which can be used as adjuncts for these indications.
As a non-allergic condition.
Non-allergic condition.
Non-allergic. Thank you. Thank you. Coming back to Dr. Anshum, can you tell us, is there any role of combination of oral H1 antihistamine and oral decongestant in asthmatic patients along with patients with allergic rhinitis?
So, firstly, oral decongestants are should always be discouraged for use, and oral decongestant, most of them actually have been banned across the globe because of concerns of stroke, pulmonary hypertension arising. So, oral decongestant combination with antihistaminic as such is not a very ethical combination, I would say, because most of the studies that were done with this combination always had shown more incidence of adverse effects. Actually, even more than just combining an antihistaminic and say paracetamol. If we combine antihistamine with oral decongestant, it has more adverse effects and less of symptomatic relief as compared to other patients. So the only relevant indication of using it would be to use it for some benefit in terms of symptoms, which is very transient. And this benefit is mostly around the first initial few days of an allergic episode. So in asthma patients per se, the combination has no role for benefit of asthma. Now, only in allergic rhinitis, if we use oral decongestant to help relieve the nasal stuffiness, then that may be used. But I would again say that in that case, we should be preferring topical nasal decongestants, and nasal decongestant spray may be preferred for an for allergic rhinitis, even in an asthma patient or otherwise. So for me, the combination is not a very viable combination. And asthma patients, there is no specific rule to prescribe this combination.
What about the basis of combination of mucolytics with antihistamines? Is there any basis?
Yeah, so mucolytics, in comparison to this combination, has a certain advantage that, for instance, ambroxol, if we use as in the combination, it does have some immunomodulatory role also. And if you look at the mechanism of ambroxol, it also exerts some antihistamine role. It also has some role with leukotriene receptors and the release of leukotrienes. So this may be a better beneficial combination, but again, in selected population where we are dealing with excessive mucus. And again, ambroxol or other mucolytics cannot be given with all antihistamines. So the newest ones, in fact, for example, belastin, given with a mucolytic will not have much role because it has a cholinesterase activity. So this combination again cannot be used with all antihistamines, but some antihistamines in selected population, yes, it can help because it also has an immunomodulatory and an anti-inflammatory role. So that way, this combination is better than giving an oral decongestant and antihistamine together.
One last question. What about the common adverse effects you have come across in the second generation antihistamine?
Yeah, so as was discussed earlier, the most common side effect in second generation has been headaches. A lot of patients come back saying they have headaches and so they don't want to use it so often. We are also experiencing this with the newest antihistamine. So that is one thing. Secondly, dryness of mouth, and also complaints regarding urinary stream being interrupted and decrease in secretions in the mouth. That is very, very common. They still have some sedative effect also. So I would not say that there is no sedation at all. It depends also on patient factors because not only does the drug affect, but if a patient has any underlying hepatic condition or a patient is an elderly, then even the newest antihistamines can cause these side effects. So most common is headache, again fatigue. Patients have difficulty in concentrating at work, much lesser than H1, first generation H1 antihistamines, but it is there with the second as well.
We prescribe, but we don't know more about the adverse effects. That's what you have made it very clear on this part. Thank you, Dr. Anshum.
Thank you, sir.
Coming back to Dr. Avishek, in the pediatric age group, which intranasal antihistamine you would prefer?
Sir, actually in pediatric age group, we can use any intranasal antihistaminic, but it should be avoided till 6 years of age. After that, we can use it. But because of its bitter taste and because of its method to give, which cause something irritability to the patient, it's better to avoid if we can. Otherwise, after 6 years of age, we can give any intranasal antihistaminic as per the requirement of the disease.
You don't want to give steroid combination with an antihistamine?
Sir, again, the combination drug, which I mentioned earlier, is again a very problematic to the patient. And what we are, I told, any histaminic doesn't treat the cause; it just gives a symptomatic relief. But when we are giving steroids, so it means we are giving it for the longer period or for a time period of duration for 14 days, 21 days as per the requirement. So if we are giving combination drug, it unnecessarily prolonging the duration of antihistaminic, which was again a point to think about in pediatric patient.
Thank you. I asked the question so that let everybody know it again. That was the reason of me asking again. You made it very clear. Thank you one and all for a wonderful panel discussion. You have answered a lot of questions. I think so today a lot of simple things have been answered. We will take the audience question. Is there any questions? I'll just find out. I just see what are the questions available for us. Yes. Dr. Sushmita Roy Chaudhary from West Bengal, Kolkata, she's asking, what is the role of antihistamine in psoriasis and how long to be given? Anybody can take this question.
So, I think in psoriasis, the main role of giving antihistamine is for the itch. So basically, because the patient has so much itching, that is why we would like to prescribe this drug. So mostly it should be prescribed more on a short-term basis in psoriatic patients, because it does not affect the course of the disease as much. And during episodes of increase in exacerbating symptoms, it can be given for, say, week to 10 days. As far as I know, I think there's no long-term role of giving antihistamine in psoriatic patients.
Yeah. Thank you. Dr. Ravindran from Tamil Nadu has asked, safe antihistamine below 1 year old children. Dr. Avishek, you already answered.
Yes, sir. Sir, it's better to avoid any antihistaminic in infant and newborn, sir. Unless there is any emergency, otherwise there is no antihistaminic which were studied, because there is very less study which were shown to the efficacy and whatever the side effect of antihistaminic in infant and newborn, sir. So it's better to avoid below age of 2 years any antihistaminic.
Yeah. A lot of questions on pediatrics only they have asked regarding the usage, what is the duration. So you answered all the question, whatever they have asked in one go.
Thank you.
Dr. Ashintosh Das from West Bengal is asking the role of steroid and dose and duration. I don't know, the role of oral steroid here asked. I don't know what he meant. I really do not know on this part. He has not mentioned anything on the antihistamine, but he is asking for the role of steroids. I think so. In what context he has asked is not mentioned. I'm just going through some more questions. Is there any? All questions have been actually answered by Dr. Suba Jothi only in the beginning, midway when he was answering taking our questions. Any more questions? I think so. We have answered all the questions. Do you have any questions? Yeah, please go ahead. Anybody wants? Hello? There are no questions on the chat box. Anybody wants to ask any questions? We have answered most of the questions. Has been answered. Whatever is there in the chat box.
Yes, sir.
So, if there are no questions, then we will conclude this session. Thank you everyone for a wonderful panel discussion. Each of them have contributed in their own way of managing antihistamine from the ENT point, from the pediatric point, from the adult point, from the pulmonology point. Everything has been covered well. Thank you one and all again.
Thank you.
Thank you.
Thank you, sir.